Welcome everyone to the online shoulder and elbow school. I'm Valentina Greco and I'm a member of the Junior Committee. First of all, I would like to thank all of you to join us today. Many thanks to Marie and SECEC for the support. I'd like to thank Dr. Yacina Mesiana, President of the Junior Committee, and Dr. Juan Aguilar, and all the other members of the Junior Committee for the help to organize this meeting. I would like to introduce the 5 young surgeons who are participating today. Blaise Cochard from Switzerland, Joao Andre Alves from Portugal, Abdulhamit Misir from Turkey, Salar Pour Jafar from Germany, and Matteo Messori from Italy. As senior surgeons, we are honored to have with us 2 clinical cases on acromioclavicular joint dislocation. If you have any question, just use the chat and we will try to ask seniors at the end of each case. Let's start.
Good evening, everybody. First of all, thank you for the invitation. It's a great honor to be here. I'm a real SECEC lover, so it's great to be part of this OSES meeting. And together with Clara, it's our great opportunity to discuss the different techniques on AC instability. One of the problems, of course, with AC instability is there are a lot of possibilities. I will try to share my screen. There are a lot of possibilities, first of all, on the diagnosis and next on the treatment. So maybe let's start a little bit with the diagnose and how the trauma mechanism is done, because I think if we understand better the mechanism of the lesion, that we can better understand how we need to treat it. So I will start with this 24-year-old right-handed male person who had a fall from a bike 5 months ago. And this is his video. So this is the retraction. You can see there is no clear visualization. And this is the protraction. Again, retraction. And again, protraction. So maybe to the junior members, how would you evaluate this patient? Do you have enough information already? Do you want me to have extra things? How do you evaluate this patient when he's coming to your clinic?
So at this point, I will just perform an X-ray just to be sure it's not a fracture sequela. It's just proper ligamentous lesion. We'll perform a clinical exam just to be sure there is no neurologic lesion as well, because sometimes I've seen some long thoracic nerve palsy. And it was also important to take care of that.
And how would you describe this lesion if you see it from a clinical point of view? Would you say the clavicle is going up, the shoulder is going down? What happened here in this trauma? Is the lesion of the deltotrapezial fascia?
Yeah, I know that. So with that, the shoulder is going. Actually, during the trauma, the shoulder is going down. And the muscle attachment, the trapezoid attachment is pulling up.
Does somebody else has another? So here, do you think the clavicle is up or is the shoulder blade down?
I believe the shoulder. The shoulder is down, and from what I see, I can already see clinically there's some kind of vertical and horizontal instability. We can see with the shrugs that the clavicle translates anteroposteriorly.
Well, just from theoretical point of view, it's not the clavicle who's translating anteroposteriorly, but it's the scapula. We always discuss the distal part that's moving compared to the proximal part, I think. Here, would you say, if we look a little bit, I will show it in the next few slides to the classification. You know the Rockwood classification. What kind of Rockwood classification do you think this is?
Normally, I use an X-ray to address the ROCUD classification and to classify it, but it seems to me that it might be a 5 grade because there's more vertical displacement than posterior.
And what's for you the difference between a 3, a 4, or a 5? How do you, if you say I don't have an X-ray, is there a clinical test you can use to see if it's a 3, 4, or 5?
Normally, the 5 and 4s, the scapula is not controllable by the patient, and because the bridge and the supporting function of the acromioclavicular joint, it's lost more than in a 3.
Sorry to interrupt you. What do you mean with the scapular control?
That the patient will have, while moving the arm, will have a dyskinesia of the scapula, I believe.
Okay, so it's in the 3, they will if, for example, if you see them in an acute situation in the emergency department, in a 3, you wouldn't see any scapular dyskinesia, and in a 5, you would immediately some scapular dyskinesia, or would you say it's in a chronic case different, or? Okay, just a question, maybe, yeah, I don't know, Abdulhamit, would you say this is a 3 or a 4 or a 5, or?
It may be all of them. I would like to see the X-ray, but in first impression, it may be 4 or 5 for me.
And you, Salar, or would you say?
To be honest, just looking clinically like that, I would say as well more 4 or 5, because during the clinical exam, during the video, I had the impression that there was a huge antero-posterior translation, and I've been thinking that the clavicle is already like posterior to the acromion. So yeah, of course we need X-rays, like everybody said. In this case, I would say more 5 or 4, yeah.
Maybe Clara can ask your.
Yes.
Yeah.
Yes. In my opinion, I don't think I need X-ray to say that this is a 5. I may be wrong, but in my opinion, the behavior of the clavicle seems to show that the delta trapezial fascia is torn. And in this case, I would classify it as a 5. But I may be wrong.
No. I think you're right. For me, also the clinical examination is more important than the X-ray. So what I ask the patients, if they're lifting up their shoulder in a shrug, and you see that at that time the AC the AC is reduced, then for me it's a 3. If it's not reduced, it means that there's some soft tissue in between. Then for me it's a 5. I can't really say on an X-ray it's a 4 or a 5. It's if you look to the classification, I think it's a static X-ray. It's not a dynamic situation to make a differentiation between a 4 or a 5. Would you say, does it really matter if it's a 4 or a 5?
In terms of treatment?
Yes.
For me, it's the same, 4 or 5.
Would you make a difference in classification between a 4 or a 5, or based on an X-ray, or based on a clinical examination?
It's very difficult. For instance, sometimes the incidents may fool you, and you may think that the vertical displacement is not that significant, and what's happening is it's posterior superiorly dislocated, and it's a 5. And sometimes it's difficult to distinguish between the 3 and the 4, even through the X-rays, because you can also have this posterior dislocation in a 3B, and it may be difficult to distinguish between the 3B and the 4. For me, the classification, for me, the clinical behavior is more important than the X-rays. and we will see this also in the clinical cases I have to discuss with all of you. Because if the patient has vertical and horizontal instability and is young, we have to address these issues probably surgically if we want to correct them all and to have the patient regain their full function for a long term. And so for me, it's more important the clinical behavior than the x-rays themselves, because I don't control, unless I'm calling the x-ray technicians, I don't control the way the incidents are performed. And as you were saying, and I agree with you, Alexander, x-rays are static. And so you don't see the behavior that you can see clinically, dynamically in an x-ray.
Yeah. That's indeed also my opinion, that the clinical examination is very important. If you look back to the video, you can see if he's retracting, it's almost undisplaced. If you would take an X-ray like this, it would be not that strange. But if you look in protraction, it's really coming forward. I always like to show this video because it shows the importance of the function of the clavicle. So normally the clavicle has the function to put the scapula in the right position, so it's in a more retracted position. And if you lose this grip between the clavicle and the scapula, the scapula will go, because of gravity, it will go down and it will go much more internally rotated. We did a study that showed there is something like 3 degrees of anterior superior translation of the clavicle, but most of it's really an inferior translation of the scapula, because the scapula is not attached anymore to the clavicle. So the clavicle remains in the same position.
But Alex, you're saying that the clavicle isn't pulled by the trapezius upward?
No. So if we look to our study but of course it's a cadaveric study that we did, so it's not an active study that showed that the superior migration of the clavicle is much less, only 3 degrees. So that's certainly not much, but most of the time it's really the inferior translation of the scapula because of the gravity. And
okay, but it's pulled up, only not that significantly. That's what your study showed.
Yes, yeah. And most of it's really the scapula that's going down.
And also regarding the posterior dislocation of the clavicle, isn't this more the scapula that's protracting?
No, we can see there is a small of posteriorly rotation because of the clavicle compared to the normal situation, but it's again much more the protraction of the scapula that's showing this type of clinical image.
Okay.
Does anyone have any other questions about the clinical examination or any other things? So I will go on. So this is his X-ray. Do you have enough information with this X-ray, or would you say I need another X-ray? Or it's you received this X-ray from the emergency department? Maybe Salar, are you happy with this X-ray, or would you have something different that will change your treatment protocol?
I would like for sure to have a panorama for both clavicle, so AP, both of them.
And what will it change in your treatment protocol?
Just to have an idea of what is normal anatomy. Because of course I don't want to over tight. If I want to bring down the clavicle, I don't want to over tight. So I want to see as well his normal anatomy. So to have an idea of what I want to do.
And would you like to have dynamic X-rays in this person, or would you say it doesn't really matter?
To be honest, if I can, I would love to. But I would use also to have the static X-rays.
And you, Abdulhamit, would you change your would you have extras X-rays or extra information?
Maybe cross-body adduction, Alexander, we may be helpful to obtain. Maybe we can see posterior dislocation level of the acromioclavicular joint, but my approach would not be changed after that.
Maybe again, it's not a posterior dislocation, but it
Okay, but I would like
Okay.
I would like to see the posterior acromioclavicular posterior dislocation level to add some acromioclavicular fixation or not. But the CC fixation is the okay, no problem. I would do CC fixation, but I would add acromioclavicular fixation too, according to that.
And do you think there will be a difference in the clinical examination, because the clinical examination showed there is a big anterior posterior translation of the scapula compared to the clavicle?
And then no, there was no huge posterior dislocation, but maybe what we saw only protraction and retraction maneuvers. We couldn't see any other stress views. I'm not sure, but it may be helpful.
And you, Blaise, what would you do? Do you think it would be helpful in this case, or would it change your treatment protocol, or?
No, the main protocol.
Like if we have like a stress X-ray.
Yes, in this situation.
In this specific case, I don't think it's useful because we have such a big displacement of the AC joint. It will not change the treatment for me.
And you, Juan?
Normally, I would like to have a bilateral Zenka view and an Alexander, but in this case, if I couldn't have another X-ray, I think I could decide the treatment I would do only with this.
Okay. Clara, do you have something to add to the?
I think if we're deciding on surgical treatment, X-rays are relatively simple exams that you can order. Even if you can't control what the technician does, we can order an Alexander view at least to document this preoperatively the best we can. I think it's and in my hands, it's unacceptable to go ahead with surgical treatment with only this incident. So I would insist on the panoramic Zenka 10 degrees cephalic tilt X-ray to really highlight the differences, even though this is static, I know, and there's its limitations, and complement it with the Alexander view, because then postoperatively I could compare and control the degree of reduction that I've achieved, not only vertically, but horizontally, both in the Zenka view and in Alexander. So I think we're not talking about MRIs, which are expensive. We're talking about X-rays. Okay,
that's indeed a very good discussion. When would you ask for an MRI? What would you say?
I wouldn't. I'm just no, never. You never say never in medicine,
yes.
But no, not typically. I use the example of MRI to say that X-rays are really cheap exams. So I don't think there's a justification to go ahead with the surgery only with this X-ray. That was why I mentioned the MRI. But just as long as we're mentioning the MRI, and someone had asked in the chat about when we do ask MRIs for MRIs, I don't see a justification if the clinical exam is so typical to order an MRI to exclude other lesions. Because it's relatively rare that they have associated lesions, and we can discuss this further along our webinar. One of the arguments for treating acromioclavicular dislocations arthroscopically is to exclude intra-articular lesions that can be treated in the same operative time. But in my opinion, the incidence of these other lesions is not significant enough to either order an MRI, which will not add any more information to my treatment protocol of the acromioclavicular dislocation, or to exclude other intra-articular pathology. Foremost, if you're going to do it arthroscopically, then I don't see any justification to do an MRI, because you're going to see all the lesions arthroscopically. So in my hands, I don't typically order an MRI in this setting.
Okay, very nice. Any other comments on the technical investigations that we need to do in this case, or? I just made a small presentation again on how the lesion starts, so how it fits with the Rockwood classification. So most of the time it's really a fall on the acromion, so the clavicle motion is blocked by interlocking of the sternoclavicular ligaments. So it starts with a superior capsule lesion just proximal of the intra-articular disc. And then most of the time the periosteum is torn on the undersurface of the clavicle. So it means it's a type 1 or type 2 if we look to the Rockwood classification. Then we get a rupture of the inferior capsule. After the next step is a rupture of the clavicle pectoral fascia. Then you get a rupture of the trapezoid ligament, and afterwards of the conoid ligament. So for me, a way to remember always between trapezoid and conoid is I will say MCLT. So medial it's conoid, lateral is it's trapezoid. And then you get an avulsion of the deltoid to the outer clavicle. And then the horizontal trapezius between the fibers that are attached to the clavicle. So you get a tear, and the scapula, like you've seen in this video, the scapula is really pulled forward. It's going down and forward because of the gravity. And the clavicle is at that time really buttoned hold through the delta trapezial fascia, and a passive reduction is not possible anymore. Maybe another question: how would you, if this patient came to me after 5 months after the injury, he didn't went to the emergency department or something like that. How would your treatment be if you see this patient in the emergency department? Would you give him a sling? Would you say you need immediately surgery? Would you say you need to wait a little bit? Would you have any restriction in movement, or would you say you can continue cycling? Maybe Salar, what would be your idea?
If I see the patient straight away in the emergency room, of course I would put a sling for sure. And my advice will be always the first weeks to rest, to just leave the patient, the shoulder, to get some rest, to avoid more inflammation, to more traumas, and also for the comfort, for most of all for the patient. So of course to avoid pain, other issues, of course not cycling. That would be any.
And why? Because I have a little bit different. Why would you say you cannot cycle? What would be the risk, or what would be the risk if he's just cycling?
Well, the position already, so he has more adduction of the shoulders when he's also getting on the bike. Of course, the risk of falling to get more injuries, the discomfort of the clavicle staying up anyway on pulling towards, or the injuries of the deltoplexural fascia, and also other risks for other injuries as well, and for discomfort.
Maybe Clara, maybe your idea.
Yes.
I never saw a patient that had a smaller injury and fall again, and then had a larger injury. Did you see this type of patient?
If this patient presented to my clinic, the one you showed, the cyclist, I would explain the advantages and disadvantages of conservative treatment versus surgical. If the patient chooses conservative, I would not forbid cycling. I've treated judo players that they just wait until they're comfortable and they go back, because this is not going to heal in any anatomic position. So if they want to do whatever they want, they can do it just as long as they can. So it's the sling for comfort until they feel comfortable to do what they want. Because if we're abandoning the lesion, for me, it's kind of indifferent. If the patient wants to treat this lesion, then it's surgical, and we schedule the surgery. That's my approach.
I have a
Can I-
little bit the same idea, indeed, that there is no risk that it will rupture more. It's already ruptured, so there is no risk that it will get worse. So this is the advantage of conservative treatment. It's already ruptured. You can do whatever you want. It will not be comfortable in the beginning, but you can do whatever they want. So if you want to have them back on track, certainly propose conservative treatment, I would say.
Yeah,
Can I
there's
ask
a very nice study by the group of Klaus Bach showing that exactly, from Denmark.
Would somebody use a figure of 8 bandage, or Abdulhamit, or would
No.
you say, or?
No, I would use it. Simply, I would try to restrict the overhead motions, overhead activities in the first 6 weeks. And if he is a sportsman and making a strength or endurance sports, maybe I can lengthen the immobilization period and make a surgical decision. But I don't use a figure of 8 bandage.
Maybe the question again, why would you restrict overhead motion?
In the first 6 weeks, because in the high level of AC dislocations, overhead motions may be painful in the first 3 to 6 weeks. And I would restrict overhead motions and strength trainings or endurance trainings. Otherwise, I would not restrict anything.
Even I would not even restrict overhead motion. Maybe it will be painful and they will not do it. But that's because it's for them, it's painful. It's not because there is a risk of extra lesions or something like that. So I would say, yeah, try whatever you want. If it's comfortable, you can do it. If it's not comfortable, yeah, you will not do it. Do you agree, Clara, or?
Completely. I agree completely. That's as you said, the biggest advantage of the conservative treatment is return to play as soon as tolerated. The doctor doesn't impose any restriction. It's the athlete that finds their comfort zone and returns as they feel comfortable.
So maybe that can be an advice in this type of patients. They can do whatever they want. Yeah. And maybe some discussion. I will finish this case because we're already half an hour on track. But maybe one other discussion. If you want to do an operation, what is the time frame that you would do an operation? Would you say whenever he has some problems, or would you say I would do it only in the first 2 weeks and then I would wait 3 months minimally, or would you say I can do it at 5 weeks, 6 weeks, 7 months? Maybe Matteo, what would you do? Is there a time frame where would you operate and when not to operate?
Maybe
I can't hear you.
Unfortunately, it's a bad connection. Maybe Joao, what would you there a time frame for you, or is it?
Yeah, if I saw him in the emergency department and we both decided that and he decided that he wanted surgery, I would treat him as an acute lesion. But if he decided not to be operated, we could wait, try a non-operative treatment, and then treat him as a chronic one, because treating it, I think there's an article by Laderman that says that reconstruction of the acromioclavicular in an early or later point of time would result in similar outcomes. So I would not be concerned with the time of treatment.
So
I
you
have a
can do that
question.
4 weeks, I would say.
So sorry, you asked.
Would you do it, for example, at 4 weeks?
At that time frame, I would have to treat it as chronic. So I would try non-operative treatment and conserve it like physical therapy to see if his pain and his function could recover with periscapular rehabilitation, to see if that helps, because the surgery would be the same at 4 weeks or at 3 or 4 months.
Maybe can I just give one comment on your say, when I see him in the emergency department and we decide to operate, I would never, in this type of cases, decide in the emergency department, because most of the time they are confused. They are everything is painful. They see this X-ray. So they're a little bit overwhelmed by the situation. If you see them back in a few days later, then they are much more relaxed, and then you can better explain. If you say you need to do an operation in the emergency department, everybody say, yes, of course, look at me. But if you see them after a few days, maybe it's already less painful, and then you can have a better discussion in the with the patient. So I would propose never to decide immediately in the emergency department that they need an operation. I don't know, Clara, if you agree, or
That's excellent advice. That's my experience as well. Usually when I was in the emergency department, I refer them to my appointment 1 week later. And if they continue to have significant pain and wanted to go ahead with the surgery, it's scheduled. Because sometimes, but it's usually in lower grades of acromioclavicular joints, at least in young patients. Sometimes they improve significantly in those few days, and after you explain the advantages and disadvantages of each type of treatment, the patients tend to choose non-operative treatment, and less other opinions have convinced them that they should have the surgery, etc. But usually, if they think clearly, they don't want the surgery because they begin to feel much better. So I agree with you.
That's a good advice. Thank you.
I think I need to stop here because I'm a little bit already over my time. Maybe Clara, will you go to your case?
Yeah, perfect. Thank you. Very happy. So let me just see if I can.
While Clara is sharing her screen, we have some questions on the chat. It has been some discussion about whether to ask for MRI in every case or not. This has already been discussed. And another interesting question is, after how many weeks would you add a graft when treating an IC dislocation in a chronic case? Thank you.
Sorry, can you, I think we already answered a little bit the first question. So for me, I don't see that much indication for an MRI for an AC instability. For me, it's really a clinical diagnosis, and I don't have clearly a different type of treatment protocol if I would see some other lesions on the MRI concerning the trapezoid or the conoid ligament. For me, it's really a clinical diagnosis. So MRI is not that important. Can you repeat the second question, please?
Yes, of course. The second question is, after how many weeks would you add a graft when treating an AC dislocation in a chronic case?
Well, that's probably a very interesting discussion. I hope we'll get there with Clara. The discussion is, of course, which surgical technique do you need to use? Do you need to put in a graft? Do you need to put in a all autograft or allograft, synthetic graft, in which position do you need to put it? I don't think there is a clear, straightforward answer for that, and everybody has a little bit his own opinion and treatment protocol, but I don't think it's a clear. Clara?
Okay, are you seeing my slides?
Yes.
Okay. Oh my God. Okay. So what we're looking at is a 31-year-old male who's right-handed. He's a manager. He plays recreative sports, bodyboarding, weightlifting every day, running, swimming, paddle, the fashion sports. And he fell bodyboarding 7 days prior to the appointment. So he was seen at the place where he was bodyboarding, and then he came back and went to an appointment with me. So it was like if I had seen him in the emergency room and hadn't convinced him to have surgery. Right, Alex? Okay.
Perfect.
So he had an indirect trauma to the right shoulder, and he has local pain and deformity. And this is how he presents to you. So what do you think, just by looking at his shoulder, João, the Portuguese guy?
So he has a deformity of the right shoulder with a drop of his scapula and a proeminence of his clavicle. So I believe he has an acromioclavicular injury, and I would like to see him moving his arms and see how his scapula behaves.
What about this? I asked him to do the cross-body adduction. Look at his face. I had to cover a little bit. He's in pain. So, Salar, what is happening here? Now he's even in more cross-body adduction. He doesn't tolerate more. He's in a lot of pain, as you can see.
A lot of pain, so stretching. Yeah.
What do you think? Do you agree with João? What do you see happening now? I'll go back. See, this is resting, and then cross-body progressive cross-body adduction.
I would say the progressive body cross. There's also as Joao said, the scapula is dropping, and the lateral clavicle tending up slightly. So of course, there's the difference between the AC joints from left and right.
Alexander, what do you think? Alex?
Yes, well, it's indeed, it's not the clavicle going up again. It's, for me, the shoulder is going down, the protraction, and you can see that it's, for me, probably the fascia here is torn. You can see that there was a little drop of the scapula. So for me, it's an anterior and posterior instability in a 31-year-old male in an acute situation. And then I would think I would discuss the several options with him.
Okay, and maybe Matteo, what exams would you order this guy? Oh, we can't listen to Matteo. Blaise, I'm sorry, I'm mispronouncing your name.
No, it's correct. It's correct. So in this case as well, I will perform an X-ray, a bilateral X-ray of the clavicular with AP view and Zanca view.
Okay, I had these slides here just to say that if the stroke test is positive, usually the deltoid trapezial fascia is disrupted, and actually in this study by Rosso and colleagues from the SECEC members, 93% of the panel agreed that this is the best test to identify horizontal instability. So exams, I agree with you. This is what we ordered. And now, again, João, what do you think about this Zanca X-ray?
So I believe the exam is done correctly. I would measure the CC distance between both arms to see where they
eyeball it. eyeball it because I have no measurements here. What would you say?
So I would say it would be between a 3 and a 5.
What, the classification?
Yeah, in the Rockwood classification, but I would like additional views to decide on that.
Because
an
clinically,
axillary
yes.
and an Alexander view.
Okay, because clinically, we all agree that it looks like a 5, right? It looks like a 5.
Yeah.
Alex, clinically. So what?
Yes, indeed, because of the entrapment of the clavicle, when you're doing the struct test.
Yes, and this also can fool you because you have no notion of the posterior displacement, right, Alex?
Yes, I would say not the posterior displacement, is the anterior translation of the
Okay, sorry, you're right.
No problem. I'm always pushing it to my residents.
No, it's great. We learn by repetition, and this
Yes,
is it's a learning point.
Yeah.
So I agree with João. So this was a little explanation of what is the Zanca, but you can read somewhere else. So I would do the Alexander, which I did. So this is, I tried to overlap it to the clinical image of the patient doing the Alexander, which consists in doing an AP view, but with the patient doing the cross-body adduction. And so, João, you ordered this exam, so describe it.
So this is the Alexander view. From here, I can see the distal clavicle overrides the acromion, where I can see that there is some horizontal instability happening.
So at this point, how would you classify this?
I would classify it as a 3B, 4 or 5. But
okay.
I saw the CC distance, so I would more say a 5 than a 3B or a 4.
Yeah, because the CC distance was double the contralateral side, maybe. Alex, I have a question for you. Alex, do you think with this X-ray, we can assess some of the protraction of the scapula or not? Is it possible to see the drooping of the scapula? This incidence?
No, I think you saw it a little bit on the first X-ray that you showed, where there is the clinical, this one. Here you can already see a little bit the difference of the projection of the coracoid, that it's different. So you can see that the scapula is a little bit more protracted in the right one compared to the left one.
Okay, great. So this was a small explanatory slide about what is the Alexander view, and if you want to read about it, it's a paper from 1954. So how would you treat this patient? Who wants to talk? Blaise.
That's a young patient, active patient. Well, it's a recreative, it's not a professional sportman. 1 week after the trauma, still painful. I will discuss with him about the 2 options, conservative and surgical treatment. And if the patient is interested about surgery, I will perform a surgery for him because he's a young, active patient.
Very well. Maybe Salar, what would you do?
Actually, as Blaise said, I would do the same probably. As he said, active player, even if recreational, young, after 1 week is in pain. I would discuss both for him and see also for him how sports is important. I mean, if you can say, let's try, then let's try with physiotherapy, and then let's see it again after 6 weeks and 3 months and discuss again at the beginning the conservative treatment. And if not, then, well, if he's more pushing for something more stable, or maybe because it thinks it's gonna help his pain much more and like that, then we can go for it.
Yes.
Can I ask a question, Salar? Why would you do a clinical examination in 6 weeks and 3 months? Would it change? What if a patient said at 6 weeks, I still have pain? Would you say, okay, now I'm gonna do it, or?
Actually, after 6 weeks, no, I would wait at least 3 months.
So he does need a consultation at 6 weeks.
No, but maybe for my conscience, yeah, maybe to see the patient also see how it's going, to see if something's happening, more pain, even if something's different also with movement. But probably, yeah, I mean, in that case, as you said, I wouldn't change my mind after 6 weeks.
So you could already see from the image that he underwent surgery. And as we were talking about this, we prefer doing this open for some, I think, 3 to 4 years. We changed from arthroscopic to open because we don't see any justification to do the arthroscopic steps because of all that we discussed. So we chose to do this technique in which we do a double bundle fixation of the coroclavicular ligaments, and we repair when in this case it was considered an acute repair. It's at 2.5 weeks. We managed to repair the acromioclavicular ligaments. We sutured them directly, and then we did the CTC technique, which I'm going to briefly show you. We control it with the Alexander view again to check that this doesn't continue to be unstable horizontally. As you can see here, this is for me the main advantage of being persistent with demanding preoperative X-rays in these patients, so that you can see their evolution. And the guy was pretty satisfied at 6 months. We've talked about the classification and the
Can I ask you a question, Clara?
Yes.
The discussion, because when you're going to congresses, there was always a discussion about a little bit arthroscopically or open, or what is there an indication for you to do it arthroscopically? Here it's
not anymore. That's what I was saying. This image you see here on the right is a patient of ours from many years ago. I used to do a single bundle coroclavicular fixation, and in most lower degrees of dislocation, it actually worked. But in most cases, what I saw was the subsidence. I had this frequently, subsidence of the reduction. So my patients went from a grade 5 to a grade 3 after 1 year. So that's why we started looking for alternatives. And the justification for changing to open, Alex, was that we can, through a small incision, which is almost the size of the incision we had to do when we did it arthroscopically, to do the tunnels on the clavicle. So we increase it a little more, and this way we can, for me it's the most important thing, do this, repair the delta trapezial fascia. Not only address the acromioclavicular joint, but to repair the delta trapezial fascia in the end, which also contributes a lot to the stabilization and to avoiding pain in patients who can have the knots that can be under the skin, and then they want to wear backpacks and it hurts them. So this was just to answer to the question about the fact that we are doing this only open and no longer arthroscopic, because we don't find that associated lesions are that frequent to justify it. When we do this technique, we don't need any more to control the placement of buttons under the coracoid, which was the most important step, arthroscopic step, during the arthroscopic repair of these lesions. Because when we do this, using this technique, we use all suture anchors, and they work like buttons under the coracoid. And since in most of the grade 5 dislocations, the grade 5 dislocations, you have a tear of the delta trapezial fascia. It's easy to go anterior to the clavicle to place the two all-suture anchors on the coracoid because the fascia is torn. And so you can control this with a fluoroscope, and you don't need to see this through the arthroscopic view. And another advantage of this technique is that we can use these sutures from the implanted on the coracoid to do this reduction of the clavicle to the acromion by placing the tunnels in this fashion, and you can see this technique on the arthroscopy journal. There's no need to lose time here showing it, but
Can I
in
ask
the end yes.
some questions about the position of the tunnels and the way you drill? Do you measure the starting point compared to the distal clavicle? Do you sometimes resect a little bit of the distal clavicle, or do you are you going from superior to inferiorly, or are you trying to go a little bit oblique? Or
one of the major advantages of this technique is that you are not conditioned by an ACL guide type of tunnel. So you're not doing a direct tunnel from the clavicle to the coracoid. You first try to drill in the footprint of the conoid and the trapezoid, these two anchors. So we want one more posteromedial and one more anterolateral. These are independent. These tunnels are independent from these two tunnels. So you use the same.
How do you drill new tunnels? The distance from the lateral clavicle border to the tunnels? Do you have...
and we control this with a fluoroscopy, so we know the direction that we need and the distance. We can see it in the fluoroscope, but usually it's 3.5 centimeters medial to the distal clavicle.
Yeah, because the way I'm doing it, if I'm using only one suspension technique, so it's one drill hole, then I go 3.5 centimeters from the lateral clavicle. If I do a two suspension like here, I would go for the trapezoid 2.5, and I'm aiming from
so here
posteriorly, a little bit posteriorly to anteriorly, because the trapezoid is attaching on the anterior undersurface of the clavicle, or the infra-anterior undersurface. And for the conoid ligament, I would go for 4.5 and aiming from anterior to posteriorly, so I arrive at the infra-posterior part of the clavicle to try to aim a little bit the direction of the anatomical ligaments as much as possible.
Great. Okay. So this is a representation, and I have another case. Do you want to move to this case?
Yes,
so this is a very young guy that comes to my appointment. I love this case. That's why I brought it to you. He's retired, right-handed. He does push-ups. He does functional exercise, very athletic for a 97-year-old guy. And he fell from his own height 12 days ago. He went to the emergency room, and they told him he had a severe lesion on his shoulder, and he had to have an appointment with me. But he arrives in my appointment with insignificant pain and full range of motion. And after I told him my plan, he started to exemplify push-ups to show me that he had no pain. So this is very interesting for me. That's why I think it's worth discussing. And this was the exam he had to show me from the emergency room. So you see, it's a gray view of the shoulder, right? But they put a weight on him. This is Portuguese. It means with a weight. Okay. So I'll ask Salar, what do you think about this exam from this patient, from his left shoulder?
Well, It seems that there's the dropping scapula.
Very well.
I will ask for the panoramic Zanka, if I can.
Great.
Just a better view. As we said, I will go also for an Alexander to see if there's the override of the clavicle. If I can ask all of them, I would be happy.
Okay. And Joao, what do you think about the displacement of the clavicle? And bear in mind, this is a Gratche. So a
For
true
me,
AP.
it's hard to evaluate the displacement, but I believe he's superiorly displaced. But what I notice is there are some degenerative alterations on the AC joint already.
Yes,
So
very well.
it might be asymptomatic, or he might already have some pain there.
Yeah,
I'll
he
ask him
almost has
that.
no pain. Blaise, what do you think?
Okay.
I'm agree with Joao and the other colleague. Well, it's degenerative arthropathy at these joints with a very old patient, asymptomatic, full range of motion. Well, I will perform a full X-ray workup, of course, just to be sure there's not something else I'm missing. But in this
Like
case,
what?
if it's like another fracture or another lesion, I don't know. It's difficult to say without any clinical evaluation.
He has almost no pain.
Well, probably just
He
that,
was-
probably just a AC dislocation.
Yeah, he was in a lot of pain when he fell.
Okay.
Abdulhamit,
Yes.
hi. I don't think I asked you anything yet.
Hi.
What do you think
Yeah.
about this exam?
Degenerative and
Okay.
it is
we
AC
can-
joint. Full function.
But is there an AC joint dislocation?
Sorry, I didn't understand.
Is the
I
AC
didn't hear
joint
you.
is the AC joint dislocated?
Could be.
It seems like that. But maybe
Okay, I was just seeing if you could see it in the picture. Alex,
Well, I don't see a superior migration of the clavicle, but I see an inferior migration of the scapula. Just a rehearsal.
thank you, Alex. But you see it. You see an inferior migration of the scapula.
Yes. Yeah.
There is an AC joint dislocation.
For me on this X-ray, I would say probably yes. Yeah, I don't know if I'm missing something here.
This is what we have. The patient and this.
Yes, well, I would do my clinical examination again to see where he has pain. I'm looking.
It's there. It's in the AC joint.
Okay, yeah, then it's for me, it's probably an AC lesion. But what type of lesion I need to have a new X-ray.
Okay, so, and do you think that this is justifiable nowadays to do the stress views? Do you think this still stands?
In my practice, not, because it doesn't change my practice, I would say.
Okay, I agree with you. I didn't order this X-ray. It came with it. So based on this, imagine that you don't ask for anything else because he's 97. What would you propose to this patient? You would insist on the exams, right? Okay, but I didn't. I didn't. I was so impressed by his push-ups, and he was 97, and I told him, I'm going to treat you as a rugby player. So off with the sling now, and go perform all you want to do. And he was so happy, started moving and almost jumped of happiness. So like the cyclist we were discussing, it's like I said, go cycle, do whatever you feel like. Don't let any different ideas stop you. If you are not in pain, you can do whatever you want. And this is the guy at 7 weeks. And this is X-ray at 7 weeks. So, Blaise, what do you think of his X-ray? Do you think there is an AC joint lesion, acute or not?
How many weeks after, you say?
7.
7 weeks after. It seems to be like AC lesion process on the left side, because there's a diastasis of the AC, like a resorption, maybe. Is it acute or not? Well, at this point, I don't know. He was not so much in pain at the very beginning, isn't it?
No, he was. When he fell, he was in excruciating pain in the AC joint.
But 12 days after, it was not painful anymore.
Yes.
At the AC.
Yeah. Well, unless you touch it there, it's a source of pain, but it doesn't limit his function or his life anymore at 7 weeks.
Okay.
At 7 weeks. Not at 12. At 12, if you touched it.
Can be a AC osteolysis after a trauma, but
Alex.
I can see indeed there is some gapping of the AC joints. So there is probably a little bit of anteroposterior instability, but the distance between the coracoid and the clavicle seems to be acceptable. So for me, it's probably a type 2 clinically. And I completely agree with your treatment protocol. Just he will do whatever he can do. And
do you still think it's a type 2?
Let's have a look again when he's going up. A type 3A.
What about now?
Yeah, well, that's something I need to feel clinically, I think. It's,
okay.
It's, yeah.
It's going posteriorly, it seems to me.
The scapula is going anteriorly, you mean?
I don't know if I'm going to survive this webinar, Alex.
All my residents are always the same. It's yes, it's.
So at 7 weeks, the guy had an Alexander. This is the first image the technician gives me of the Alexander view. What do you think?
There is.
What about this?
Overriding, yeah. It's.
It's overriding, so he did have an AC joint dislocation. And
yes, but indeed the question is, does it really matter here? It's in this type of situation. I would say.
I think he has a difference in the behavior of his scapula, Alex. But he's very happy. This rugby player at 97.
No, impressive clinical examination, but it shows that the most important thing here is that we need to evaluate the patient and not the X-ray.
That's it. That's the morals of this story. Do you want to show your second case?
I think it's finished. It's
Oh, it's finished. Oh,
yes.
sorry.
Yeah, great cases. Thank you so much. We finished our time, so we're so sorry. Juan, do we have some question for the seniors?
Yes, we have had some questions, but as we don't have a lot of time, it's interesting. An interesting question was do you think a CT scan is ever needed on an AC joint dislocation? You find it helpful in some situation?
In my practice, no.
In mine, neither, unless you have a suspicion of another fracture that you're not being able to diagnose, but that's very difficult to imagine that you wouldn't have that suspicion clinically, that you couldn't see it in the x-rays. So not systematically, no.
Great.
Right.
Maybe there was a
Alright.
good question about the hook plate as the last question. Do you think there is
Yes, we
also, some room for a hook plate, Clara?
Well, this is something where I would almost say never, because it's you're going to damage the exact same joint that you're trying to treat using the hook plate. So in my hands, there's no justification. Then you have to remove it. Then it can cause problems with the rotator cuff. Also, it's very rigid. We need these joints to be moving. So you can't leave that implant there ever. So I don't see how it has a place in the modern treatment of AC joint dislocations.
Yeah, me neither. I think there was a good option in the past, or good. If there was an option, these were the things that were used. But I think the current techniques are better.
All right. Thank you all for participating. We encourage you to continue sending application for future OSES opportunities and to apply. Additionally, we invite you to become a junior member of SECEC and to attend the SECEC Congress in Munich, where there's a special prize for junior SECEC participants until the 15th of June. Professor Azevedo and Professor Van Tongel, thank you to share with us your experience. We had a chance to learn a lot from you. Thank you to all the participants and see you. Bye.
Thank you.